After having my second child, I ended up with a nasty sort of back problem after that. And I went to see all the cool kids in physio land and tried to find somebody that could help my problem. And ultimately, nobody did. Ended up in a lovely neurosurgeon's office who offered to do a bi-level disc replacement for me. And it was that point I started to I guess have pretty serious doubts about my profession and my ability to, help other people when I couldn't even help myself. So I sort of went back to the research at that point to try and find out, well, what was new about chronic pain? What was I obviously missing? Because, I couldn't fix my own problems.
Okay, welcome everybody. We've got Dr. Field here. Dr. Field, thank you.
Hello.
Yeah, okay, good. Well, welcome. You're in, my understanding, maybe you're in Australia. Is that correct?
Yep, that's correct. I'm a couple of hours below Sydney.
Very good. Yeah, it's always a fun from different times of the world because of the time zone. I like the vertebra behind you, the little skeleton there. Spent time looking at plenty of those for my career. So let me ask you just if you would be so kind as to just kind of give a little background on who you are.
Yeah, sure. So I'm a physio, obviously. So I've worked as a physio for about 30 years, mostly in private practice. In the last probably 10 years, I've had a particular interest in chronic pain management, and went down the rabbit hole of doing a PhD in that area, and just recently finished that. So I guess the area that I work in, I still work in private practice, but I work specifically in a pain management program with a psychologist, and that's what we do on a day-to-day clinical basis. So the people that we see are the guys that have had long-term chronic pain. So, people that have had chronic pain for usually years by the time they see us.
The term physio is foreign to the U.S. audience.
Oh,
So,
sorry, physical
'cause they
therapist, I
don't,
think you call them.
there you go. There you go. Okay. Because a lot of people are familiar with that term. I've heard it many times. I used to live in New Zealand playing rugby, so I'm familiar with that, but many of the Americans have not kind of run into the term physio. So what got you interested in chronic pain?
I had chronic pain. That's how I ended up in the space. So after having my second child, I ended up with a nasty sort of back problem after that. And I went to see all the cool kids in physio land and tried to find somebody that could help my problem. And ultimately, nobody did. Ended up in a lovely neurosurgeon's office who offered to do a bi-level disc replacement for me. And it was that point I started to I guess have pretty serious doubts about my profession and my ability to, help other people when I couldn't even help myself. So I sort of went back to the research at that point to try and find out, well, what was new about chronic pain? What was I obviously missing? Because, I couldn't fix my own problems. And that's when I started to get into the new research in the area. And I guess chronic pain is a little bit like the nutrition space. There's some cowboys in the area that are doing new stuff that's a bit different to all the old type of pain management. So I got very interested in the new research, which is very much more along the lines of the idea that pain is a protective device, and over time it can become overprotective, and that's what's happening in chronic pain. So it's a neuroplasticity problem as much as it is a structural problem, which is where we often tend to get stuck when we're trying to treat chronic pain. And so I did a big dive into that area, trying to learn a bit more for myself, and ultimately found that most of what I learned at uni wasn't right about chronic pain management. And once I took a different approach to that, then I solved my chronic pain problem, and that's when I decided to help others in that area as well. And it just sort of, I guess, ran a bit parallel with my nutrition interest, in that I was always a bit of a chubby teenager and a chubby person as well. And so I was always on some sort of diet, and having grown up in the 80s, I was always on a low fat, high aerobic exercise regime, trying to manage my weight, and happened to stumble across low carb diets, which worked really well for me. And so again, because I was sort of interested in physiology and the science of things, I sort of went down that rabbit hole and realized there was a whole heap of stuff about low carb and ketogenic diets that matched up very nicely with problems that we've got in the nervous system sensitivity and in pain management as well. So I thought, there's got to be people talking about this stuff. So I went and had a look, and there wasn't. So ended up doing a PhD on it.
Interesting. Yeah, there is. In fact, you may be familiar. There was a recent study that came out, I think, not too long ago, looking at ketogenic diets and chronic pain, and lo and behold, it showed a significant beneficial effect, which doesn't surprise me having seen. I mean, I don't know how many people I've seen now that have gotten out of pain, whether it's chronic arthritis or some other, sort of more central nervous system type or peripheral nerve type pain that happens. Um, the neuroplasticity part is interesting because you're saying that if you're exposed to chronic pain, not is the pain, but it's also having an effect upstream in the central nervous system and in the brain. Is that fair to say?
Yeah, yeah. So the analogy I sort of use with clients when I'm trying to help them understand what's going on is it's a little bit like a car alarm. So if we're talking about an acute pain situation where somebody's just had an injury, well, that pain is then a protective device to make you sort of slow down and stop a bit so that healing can happen. And then that warning or that protection should go away and you get back to doing your activity again. And so it operates a little bit like a car alarm. So when somebody's trying to break in and steal your car, the car alarm goes off and tells you in real time what's actually going on with the structures and the tissues. But with chronic pain, it's a little bit more like, somebody's got that car alarm and turned it up really, really sensitive. And so now everything turns the car alarm on. And so with chronic pain, it's less and less about the structure that was hurt in the first place and more about a problem that we've now got in the nervous system. And the nervous system, I guess the technical term is it upregulates itself or it becomes more sensitive so that, the danger signals that are coming from the body get amplified, and the experience that the person has then is chronic pain that feels very much like, there's a problem still going on in the tissues, but that's only probably a small part of it. It's now it's almost like we've got two problems now. It's a bit about the stuff that was hurt in the first place, but it's more about the management system or the nervous system that looks after that body part as well now. So that's I guess the neuroplastic change that we're talking about. There's changes in the way that those nerves function and how they sort of talk to each other, and the way that the networks in the brain process that information. They all become more hyper-excitable. And I guess that's one of the areas that we were really interested in when we're looking at a ketogenic diet, because we know a ketogenic diet is used for managing epilepsy. And if you think about what epilepsy is, it's sort of like the end of the spectrum of something being hyper-excitable in the nervous system. But chronic pain sort of a little bit of somewhere along that spectrum as well. So we've got a nervous system that's now more excitable than it should be and wanting to trigger off too easily. And a lot of the medication that we use for people with chronic pain includes drugs that are anti-epileptic or anti-seizure drugs like your Lyrica and those sorts of things. So, there's that commonality which made me sort of prick my ears up at the time, think, hang on a minute, here we are giving people drugs that aren't really that effective sometimes for chronic pain, but we've got a nutritional approach that we could use that does the same, it has similar mechanisms that we're talking about. That's what we should be trying for people with pain.
Yeah, it's interesting there. I'm sure you're familiar with the terms. There was something that used to be called RSD, or reflex sympathetic dystrophy. It's now been replaced by the term chronic regional pain syndrome. And I think there's different subtypes of that now. And we would see someone that was maybe post-operative from surgery, and the scar is healed, but they're extremely, extremely even cloth on their skin would set them off, and they just have this hyper aesthetic sort of just increasing amounts of pain out of proportion what we normally see. And one of the things we try to do is get them to desensitize by moving and sort of trying to reach them. But it's interesting, you look at that, the drugs that shut down neurotransmission, some of the epilepsy drugs, and gabapentin is also one that's big,
Mm.
as you probably familiar, you run into that quite a bit. It's got a lot of side effects associated with what is the state of the art in the conventional world with regard to pain management outside from data? If I go in with chronic pain, I've got, I don't know, L5 radiculopathy, and I've been through therapy and all this stuff. And what kind of rabbit hole might I run down?
Mm. So I guess, well, in Australia, what would end up happening is you'd be sent off to a pain specialist generally to try and then deal with the problem. It's sort of like you go through all the process of seeing, orthopods and neurosurgeons and having whatever procedures done. And if none of that works and you've still got your pain, well, then your last resort essentially is pain management is the current thinking. And I must admit, up until this point, nobody's even considered thinking about anybody's diet. All we've done is, do procedures or give people medication. And once the pain management people get involved in, I guess the old school of thought, and what still probably tends to happen a bit, is the approach where often people get sent into like a hospital for a 2-week inpatient program or something like that. And I guess the philosophy behind a lot of those programs is, sorry, we've tried everything, you've had every procedure and seen everybody, and we really can't help your pain. Nothing seems to have made it any better. So what we're going to do is help you just to learn to live with it and suck it up, so that, your pain, we don't expect your pain is going to get any better, but hopefully we can help you just get on with your life and learn to live with it. And that's very much an old school sort of approach to thinking about chronic pain now. Whereas if we're thinking of the new neuroscience and what that's teaching us about neuroplasticity, what we know is that what's been thrown at the system up until this point has caused it to become more sensitive, and it's adapted in that way. If we can figure out what those inputs are and change them so that you're throwing something different at the nervous system, it's going to adapt in a different direction. That's the beauty of neuroplasticity. So, the new thoughts around pain management is really that, it's not good enough to say to somebody, oh, look, I'm sorry, you're just going to have to learn to live with your pain. What we know is we need to try and work out what's made that system more sensitive, and we approach it thinking about it in terms of threat and safety. I talk to people about their threat buckets and their safety buckets, and there's all sorts of things that go into that threat bucket. And whenever the brain comes up with the conclusion that danger is imminent, or protection is required, then it will turn up the sensitivity in that nervous system through those neuroplastic means that we talked about before. And so really, to manage chronic pain now, we need to take that big step back and say, okay, we actually have to change the answer that the brain's coming up with. We have to get it to say, oh, that wasn't quite as bad as what I thought it was going to be, because that's then going to help to down-regulate that nervous system sensitivity. So, there's this new approach that we need to be taking with chronic pain now. But unfortunately, in terms of what's average treatment for chronic pain now, that's not really happening, or it's starting to happen in Australia. I don't know what it's like in America, but there's still a lot of people being treated in a way that's very suboptimal for chronic pain.
You are unfortunately put on opioids for life, and they end up with significant problems associated with that. Let me ask you, with regard to neuroplasticity, for the change its connections and change how things are transmitted. Um, the I remember they used to do things called procedure known as a, well, there's several, but one that I was familiar with, something called a stellate ganglion block, where they would do an injection in the stellate ganglion up around your neck for upper extremity problems that supposedly has some benefit to that. Does that have an impact on this neuroplasticity that you're talking about, do you think?
So I guess a lot of those sort of procedures are done by the pain specialist before we actually see them, because we're a private practice. Like, they've already sort of been to the pain specialist, and then he sort of had to go at all his different techniques before they get sent on to us. So there's lots of different techniques like that, various injections, spinal cord stimulators, all sorts of things are popular out there at the moment. But overall, I would have to say I'm not sure how effective some of those things are, because the problem when you're thinking about neuroplasticity and brain-driven changes within the nervous system, if you're injecting something, or trying to do some sort of procedure, then you're really only putting a band-aid on the problem. You're not actually changing the way the brain is actually processing that information. And so, sure, you see some people that do get benefits out of those type of procedures, but we also see an awful lot of people that don't get benefits from those, because you can have those things done and they ultimately don't change the way that the brain is dealing with that question of whether we're safe or we're not safe. And so really, we take a different approach to looking at things. So obviously I work with a psychologist, and we're really looking at trying to change how people are understanding what's going on with their body, how they're perceiving their pain and the role of that pain, but also looking at all the other things that go into that threat safety equation that their brain is doing. So it includes things like, whether if it's like a workers' compensation claim, how they're being treated by the insurance company, how they're being treated by the employer, what doctors have said to them, whether they've been told they're going to get better, they're not going to get better, what their scans look like. There's all of that stuff that goes into your brain, deciding whether you're safe or whether you're not safe in any situation. So whilst there's a lot of those procedures out there, and as I said, I'm sure there's some that do work for people at times, there's an awful lot of people that don't get help by those things as well.
Well, let's fast forward to what you guys are doing. What does your regimen look like? How do you address somebody that comes in with, let's say they've gone through the hoops, they've had their corticosteroid blocks and the procedures and been to therapy and all that stuff. Where do you do what do you do that's different, and how does that seem to impact them?
So our program is mainly an education program. So they see both myself and the psychologist, and we do a lot of this education around helping people understand that these sort of concepts that like pain is a protective device, but it's not a detector. It doesn't actually tell you exactly what's going on with the tissues or whether there's been damage to the tissues necessarily. We help them understand the different concepts that give them lots of examples to try and help them understand how a nervous system can become more sensitive, and that we don't there's no such thing as a pain nerve. A lot of people get a little bit confused by that. They have a bit of a mental picture, I guess, that pain is something where you hurt yourself, and so the pain is detected by the pain nerve, and that sends the information to your brain to tell your brain that you've got pain. But it doesn't work like that. We've got nociceptors, which are actually danger detectors, and they tell the brain whether there's something dangerous potentially happening in terms of pressure or chemical or temperature. The brain then has to process that information and decide whether it's important to have a protective response based on that. So there's lots of education we do to try and help people understand exactly what's going on, and how they've actually developed into a chronic pain problem. Because if they can sort of make sense of how they got there, then they can sort of see a little bit about what we need to change, what we need to throw differently at the system to get it to adapt in a different direction. And so everybody's unique. They all come in with their own pain stories about what's happened to them to ultimately get their brain to upregulate their nervous system. And so we then look at all the different levers that we've got to pull in terms of trying to change that evaluation that's going on. And the one that I really like to use, obviously, is diet from that perspective, because it's one that has generally not been looked at by anybody up until that point. Diet is totally ignored, essentially, when it comes to pain management. So that's something then that I do with people, because it's a new thing that they haven't thought about, and it's something that they can have some control over as well. A lot of people, when they're in a chronic pain problem, they sort of feel like they're in the bottom of this big black hole and they've tried everything and nothing that they do works. So it's all hopeless and helpless, and what point is there? Whereas if we can say, okay, well, actually, here's some really good reasons why changing your diet could improve this nervous system problem that we've taught you about, and it's something that you can do quite easily. Let's have a go at doing a dietary intervention. And most people are really quite keen to do something that's different, and it has, the flow on benefits of usually helping with their mental health, and often they lose a little bit of weight and all those other things that go into that process of helping then ultimately the brain come up with a slightly different answer about how dangerous things are for them at that point.
Yeah, a couple interesting things. I want to comment, when you talk about the brain's ability to sort of sense danger, we have this nociceptive input. And like, for instance, when I was playing sports, I was out in the rugby field running around smashing in, I didn't feel pain at the time. Well, hours later, I realized that was in the drive state of competing, then I didn't have time for the pain. If a bear is chasing me and I have a
Mhm.
sore knee, I'm not going to be thinking about
You're
that
not
because I
thinking
got
of it.
brains telling me I got bigger things to worry about. Right. When I'm in the better, sitting down, then it's a different situation. One of the things that I often will see, because I remember just to be honest, whenever we would have chronic pain patients come into our surgery, we'd always kind of sigh a little bit because we knew it was always going to be, it's going to be a problem. And often those are people that didn't take care of themselves. They generally, maybe they were smoking, maybe they had a horrible diet, and maybe that contributes to their susceptibility for this chronic pain situation. So when you get these people that come to see you, I imagine some of them are in that situation where they just got awful, awful lifestyle, lifestyle conditions. And do you find that an impediment to convince people, hey, you need to quit smoking, you need to clean up your diet, and they haven't done it for 30 or 40 years? Is that a problem?
It is a challenge with some people for sure. But I think it's something that they haven't really considered often until that point, and so it gives them something new that they can actually, attempt to, to do that might help their pain. One of the first projects that I had to do as part of my PhD, we did a cross-sectional survey of a stack of people with chronic pain, just to find out those sort of questions about, like, did they actually think their diet was important, and how good did they think their health was, and how good did they think their diet was. And when we looked at the results, it's funny because most people would actually say that they had a pretty good diet, but when we actually looked at it, they didn't have a very good diet. And over half of them would say, that their health was good, but there was an average of 3 comorbidities. So, they usually, had high blood pressure and they were overweight, and they might have had a, anxiety, depression or something in there as well. And we know that the average chronic pain person has at least 3 comorbidities. We've got a big data set that gets collected in Australia from all of the tertiary pain management centres, both in Australia and in New Zealand. So there's something like 30,000 people each year that go through that service, and they're keeping all the statistics for those. And they look at the metabolic health of people coming through, and there's huge amounts of obesity and other metabolic dysfunctions when you look at that. And so the average chronic pain person has 3 comorbidities, and I think the average BMI of the people that we surveyed was over 30. So the person that's coming in to see me with chronic pain, it's you don't tend to get people that they're the picture of health, and the only thing that's wrong with them is this, rip-roaring knee pain or something like that. They've got other things going on as well. They're overweight, or they're pre-diabetic, or their blood pressure's up, or there's all these other things, and they all sort of tend to get put in a different, place from the GP's perspective. That's a different problem to have to sort out than the pain management, whereas it's all part of the same problem. It's all the same brain deciding, how am I going? Am I safe or am I not safe? If you're overweight and obese and your blood pressure's up, then I contend that your brain is putting that into your threat bucket and adding to the reason as to why your nervous system might potentially need to be upregulated so that it knows what's going on. So absolutely, metabolic health is something that needs to be looked at, and as I said, has generally been totally ignored up until this point. And most people are quite open to look at other strategies once they've got to that point. And I guess, I would love to see it being brought up way back earlier in the management process. So back when they're first having, recurrent pain problems and they're seeing their GP, that's when I'd love the GPs to talk about that sort of stuff. But I understand with time constraints and things like that, it tends to not happen, and it doesn't sort of get considered until it's a last resort somewhere further down the track.
Yeah, I've lamented that as well. I think the fact that we put diet as a last resort, and so many people that have come to us, they've done it out of desperation, and had they
Mm.
done it early, they could have avoided years, maybe decades of suffering unnecessarily. What, as far as, because chronic pain is not just a single thing. There's obviously different types of pain that are out there. What are you finding? Are there any that consistently respond better to diet than others, or some that don't seem to respond as well? Or what seems to be your response rate overall?
I think the ones that have an underlying inflammatory component to it tend to see more remarkable results sometimes, although we do see results all across the board. In the clinical trial that we ran, we didn't sort of specify a particular type of chronic pain that we wanted. It had to be just musculoskeletal chronic pain. So we had everything ranging from like your rheumatoid arthritises to people with chronic plantar fasciitis and things like that. So, and overall, we saw a significant improvement in pain. When you looked at individual people within that, there were some that did really well and some that didn't do very well at all. But obviously, our trial wasn't big enough to really be able to pull apart, which type of pain presentation is going to respond best to diet. When we did a previous part of the PhD was doing a systematic review and a meta-analysis of all of the dietary interventions that had been done for any type of pain presentation. So when we looked at the literature, that was maybe 2 years or so ago now, there was about 44, I think, studies that used a diet for chronic pain. And there was a whole smattering of different sorts of diets in there, everything from your vegan, vegetarian, through to gluten-free. And there was one low-carb in there as well. But what we saw when we did the meta-analysis and put that all together was it really didn't matter what sort of diet or what sort of pain presentation, they all had some sort of benefit from going on a diet. And our I guess conclusions from that were the things that were common amongst all of those diets was that you're cleaning up the diet a little bit. You're getting people to pull out processed foods and you're asking them to eat whole foods. So something about the quality of the diet did matter. But when we then went and did the clinical trial where we used specifically a ketogenic diet, again, we had a smattering of all different sorts of pain presentations, and they all, we got a significant pain improvement when we looked at them overall. But when we looked at individuals, something like the lady that had the plantar fasciitis, and so she'd had I think she quoted it was about 6 or 7 out of 10 pain for a long time, as well over a year or so that she'd had this plantar fasciitis pain. And within, I think it was probably 3 weeks of doing the ketogenic diet, she'd gone down to 0 out of 10. And totally got rid of the chronic plantar fasciitis. And when we checked her 3 months down the track for review, it was still gone. So it can have really quite dramatic effects. And that's somebody that had been doing the physiotherapy or physical therapy and doing the, other drugs and things like that, and nothing had made any difference until she actually changed her diet. So when you see stories like that, you really think, everybody should be offered that opportunity to change their diet and try that as a pain management strategy, because in some people it can really be quite remarkable, the pain benefits that they get from it.
Do you find that there is an independent effect from weight loss? A lot of people just say, well, just lose weight. If you just lose weight, that's 99% of the effect. Where I've seen people that weren't overweight and didn't lose weight, and yet they changed their diet and saw an improvement independent of quality versus weight loss.
Yeah, so weight loss is an interesting part of the story because, often we like to look at things logically. And so we would think, oh, okay, somebody's going to lose weight, then biomechanically it's going to be putting less strain on the affected joint and that sort of thing. And of course, that is part of the story. But you also see pain reductions when in joints that are non-weight bearing. So, if somebody's got, arthritis in their hands or something and that pain improves, well, that's not necessarily going to be related to a biomechanical loading problem. And you can also see somebody that's quite overweight and they only lose a small amount of weight, but they get a pain benefit from it. So if you've got somebody that's, 150 kilos and they lose 10 kilos and their pain improves, well, the difference between 140 kilos and 150 kilos on the knee strain is probably not all that great. But if they're getting a pain benefit from losing even just a small amount of weight, then something else is going on there as well. And so we know that, adipose tissue itself puts out inflammatory cytokines when it's under stress. And so, if those fat cells are being compressed or, they're filled to capacity, then they're under threat, essentially, those cells. And so they will produce inflammatory cytokines as part of that protection process that's going on. And so if we go back to this whole idea of chronic pain being a balance between threat and safety. So if you've now lost just a little bit of weight and taken just a little bit of pressure off or a little bit of stress off that adipose tissue, and it's no longer under as much threat and it's producing less inflammatory cytokines, and again, you're going to have a pain benefit from doing that. So we did see when we did our clinical trial that our the group that was on the ketogenic diet, they did lose a significant amount of weight. So I think there was an average of 5 or 6 kilos or something like that was lost doing it. So there was probably some component to weight loss in the pain benefit that they had. But as I said, we know that there's other things going on there as well. So even if we can only get people to lose a small amount of weight, there's potentially still pain outcomes that can improve by doing that.
Yeah, that's something I saw as a surgeon when I was putting preoperative patients for, say, knee replacement or hip replacements on ketogenic diets. Very often with trivial weight loss, they'd come back in and say their
Mm.
pain is gone. We don't need to do surgery. And so I said, that's great. We can skip the surgery. Let me ask you a little bit going back to neuroplasticity. Um, is there any way we can assess that, or like imaging studies? Can you do like PET scans or functional MRIs on somebody in chronic pain and say, this is the signal I have now, and can we see change? Is there any research with regard to that stuff?
I'm not aware of anything like that, and that's the difficulty, I think, when people are getting imaging and stuff done. People come back with MRI scans or whatever it might be that show some sort of structural anomaly, and again, our brain wants to join those logical dots and say, okay, well, that must be the thing that's causing the pain. But those scans things can't show you what's going on with the nervous system or how it's processing or doing things. So we don't. I don't know of any sort of assessment procedures that are used clinically that show you that sort of thing. When you're looking at nerve conduction studies for something like carpal tunnel, you're really only looking at a piece of that nervous system and how it's actually transmitting the information, but it's not really looking then at how that information is being processed in the brain or anything like that. There is a lot of research going around in the chronic pain area looking at transcranial stimulation and trying to look at stuff going on that way. And I'm not sure whether they are getting into that area of looking at whether, being able to quantify what sort of neuroplastic changes has happened. But so in answer to your question, no, I'm not really sure of anything that tells us that sort of information.
I'm aware, like some like diabetics, for instance, ones that are suffering from peripheral neuropathy, which can be tingling or a burning pain, will often state that they can tell, like when their blood glucose gets higher, they have more pain or they notice their symptoms more.
Mm.
Are there any relationships with that with chronic pain? Let's say maybe when ketones are higher, their pain is less. When glucose is higher, their pain is worse. Do you see any of those relationships, or is anybody looking at those things?
I don't think anybody's really looked properly at that to see. Like, that was my assumption going into our trial, that, I was going to be able to see that those people that did the diet well and got higher ketone levels, they were going to have the better pain outcomes. But it didn't really turn out that way. And again, our numbers weren't big enough because it was only a pilot study. Their numbers weren't big enough to do that sort of analysis. But the other thing that was interesting that I wasn't expecting out of the trial was that the people didn't get really high ketone levels. I was expecting, that we're going to have people getting, over 1.5, 2 to have some sort of clinical significantly important change in their pain outcomes. But the average ketone level was it was like 0.4 or 0.5 or something like it. It certainly wasn't very high at all, but yet people still got really significant pain outcomes. There were people within, when you're looking at individuals, again, there were some that sort of got up to, 1.5 and stuff, but the average was still much lower than that. And we still got good pain outcomes. So again, whilst ketones then are part of the story of what's going on with chronic pain, there's a lot more to it, I think, that we don't necessarily understand. And as you mentioned, this whole idea of, what is the glucose level actually doing to the nervous system is something important to consider. So, when we think about what happens when you go on a low carb or ketogenic diet, not only are you switching to fat for a fuel and producing ketones, of which they are signaling molecules, by default, you're also reducing the amount of glucose that's floating around in the system too, and you're not getting the same sort of wild glucose excursions. And we know that, if glucose gets too high, then it will glycate or attach itself to proteins, and those proteins don't function properly then. And we tend to focus on what happens with, the HbA1c and how it, affects the proteins in the blood, but it attaches to the proteins in your tendons and your ligaments and your nerves, as well as evidenced by the fact that, diabetics get neuropathy. So by not having that high level of glucose all the time, then that has to improve, the nerve function, and also, the function of cartilage and other tissues like that, because those proteins that are glycated or advanced glycation end products that we call them, they have their own receptors within cartilage and stuff like that. So if they are present, they will trigger inflammatory responses in cartilage and cause an enzyme which actually degrades the cartilage. And so often, I think, the historical, or the classic view of what's going on with arthritis and things like that, is that it's a very much a mechanical based problem, and we've overloaded and overused the joint, and so now the cartilage is starting to wear out. But if you've got a situation where there's lots of high glucose all the time, that is also going to trigger physiological responses which cause cartilage to break down also. So if you've got somebody with arthritis pain and all you're doing is pulling the sugar load down out of their system, and their pain improves, it could just be that you're now helping to reduce that inflammatory response that's been happening in the cartilage due to the high sugar levels.
Yeah, there was an interesting study looking at synoviocytes, which are the little cells that produce synovial fluid, and they saw that those exposed to high levels of insulin, hyperinsulinemia, which just goes hand in hand with,
Mm.
glucose dysregulation, were more prone to produce these inflammatory cytokines within the joint themselves and leading to, damage eventually. Um, Let me ask you about, I mean, what was it when was there the diet you prescribed? Can you describe that? Did it contain those awful things like meat and eggs and all these horrible things that we're told to stay away from? Was that part of the diet?
Yep, all those terrible things were in there. So we did a whole food diet. We were very clear about it needed to be a low. So part of the way we ran the trial was that we did a 3-week run-in period first, where everybody had to pull all of the ultra-processed foods out of their diet. So we used the NOVA classification system to help them understand what ultra-processed foods were. And so the aim was we didn't talk about carbohydrate or anything at that point. It was just we wanted you to clean up the diet so that we're comparing the same sort of thing here. And so then at the 3-week mark, we then randomized them to either keep doing that diet and just keep all the ultra processed food pulled out of the diet and cook it yourself at home and that sort of thing, or that diet plus we were going to reduce the carbohydrate as well. And so part of what we did with that, the way that we helped them understand the ketogenic diet, was that they had like a glucose and ketone monitor so that they could do finger prick testing. So rather than say, this is the specific number of carbohydrates we want you to eat, we sort of ballparked it at about 50 and said, okay, well, you're going to actually have to measure your ketones. And if you're not getting any ketones, well, you need to sort of keep trying to pull your carbohydrates down a little bit further. So it was giving them sort of objective feedback at the time to know how they were going with the diet. But the other thing that we did that I think was important was we did another study. So myself and Jessica Turton, who's a dietitian that was at the uni with me, who's also currently doing her PhD, and she's looking at ketogenic diets for type 1 diabetics. She's running her clinical trial at the moment. But the thing that we did was we went back and we used the Australian and New Zealand food database to come up with a list of the top 10 low carbohydrate foods for all of the different vitamin and mineral categories. And so we used it based on serving size. And we also played the game and used the serving sizes like our dietary guidelines would suggest. So that means essentially you're penalising red meat and things like that. So we wanted to, make it look like we were following all the rules as we did this. And when we did that, we came up with this top 10 list, and it was a really quite an interesting list of foods that came up with. And the way we used it in the trial was it was a little bit like a bingo list. So I gave them a bingo sheet, and the idea was that they could look through all these foods in each of the categories and try and make sure they were eating something out of each of those categories over the space of a week. But when you looked at the 27 nutrients that we assessed, the 80% or 16 of the 27 groups had more than 80% animal foods as the top 10 low carb foods. So there was only, I think, 3 groups, which was, I think, vitamin C, magnesium, and B7 maybe, that had that had more plant foods in them than animal foods. So it's a really nice list of what we would consider appropriate foods to be eating. And we're actually trying to get that published at the moment, but we're having some trouble getting it through review because they love to hate on low carb studies. But we designed that to be a resource for clinicians, essentially, so that when you're trying to formulate a nutrient replete diet for somebody, here's a way of doing that and helping them come up with ideas about what foods that they can eat, and knowing that the majority of those foods represented are animal-based foods.
Having that list to choose from, do we know what they actually chose? And did they have a food diary, or I'm sure you guys had a way to assess their compliance?
Yeah, so we had a pain diary that they had to fill in every day, and in that they had to rate how compliant they were with the diet. And intermittently through that, we did a food recall as well. But we didn't really keep track of how well they followed, like that low carb list and that sort of thing. It was sort of getting a little bit beyond the scope of the of the research project that we were doing. But that would be the sort of thing that would be interesting to look at now, is to actually assess the quality of low carb diets a little bit more closely, to be able to show that these are good diets, they are meeting all the nutrient requirements. And that was the thing that we did. So we did a dietary plan from those lists that we came up with, and from that 3-day plan, we showed that it covered all the micronutrients, and all the vitamins and minerals were covered by doing that. So you can eat a diet that's quite high in animal products, and it does meet all of the nutrients that are required for healthy diet, healthy living.
Yeah, and well, I have my own perspective on that because I eat an exclusively animal-based product diet. I've been doing it for 6 years, and I'm not dead. I'm doing well. Question for you. So did you guys assess inflammatory markers, CT, IL-6, anything like that? Was that part of the outcomes?
Yeah, so we did blood testing at the 3-week mark and then at the end of the 12 weeks of the diet, and that included HSCRP as one of the markers. And so we got a significant improvement in that inflammatory marker for the ketogenic diet group, so not for the whole food group. So I think the important thing probably from that trial to in terms of the outcomes, firstly, both groups did get a significant improvement in their pain outcomes. Just even the group that only pulled out the ultra processed food did get an improvement. But the improvement was probably greater in the ketogenic group, and they had other things that improved as well. So their inflammatory markers improved, their weight reduced, their anxiety and depression scores improved, and actually both groups got an improvement in the quality of life markers that we did as well. So I think, from a clinical perspective, the take-home message, I guess, from the trial was that, even if all you can do is, at that starting point when you're, seeing somebody early in the stage, if you can just really encourage them to pull the processed foods out of their diet, then that's a good starting point for pain management. But then, further down the track, doing something like a ketogenic diet as an actual treatment intervention has the potential to actually get more benefits as well. So we could get better pain outcomes and improvements across other areas as well. So yeah, it was. I think it's good to sort of look at those outcomes and really try and promote the idea of just reducing the ultra processed food. And I guess the other thing to look at, the group that did just do the removal of the ultra processed food, by default they actually reduced their carbohydrate as well. So it didn't get down to what we'd classify as a low carbohydrate diet, but they went from like 300 grams of carbohydrate to, I don't know, 160 or 70 or something like that. So even though it wasn't below the 130 that we'd use to classify a low carbohydrate diet, for them, they actually reduce their carbohydrate quite significantly. And so when we think about what we're doing when we're reducing the carbohydrate, like we were just talking about, all those potential improvements by having that lower glucose load and those lower glucose fluctuations, then that might be the reason why they also got their pain improvements too. So there's lots to think about when we're thinking about diet and pain management.
Yeah, I mean, that's an interesting point, and I think it bears repeating that, even though we remove ultra processed foods from both diets, the one that had, I guess, lower carbohydrates even outperformed that. So uh, at least when it comes to pain management. And then you also noted the other outcomes such as depression and anxiety, which I see every day. I can't tell you how many people that used to be depressed are no longer depressed by going on extremely low carb animal-based diets, which I think is really, really remarkable. What was the compliance? Did you guys dropout rate for the? I don't know how many people were in the pilot. I know there's usually 20 or something. I
Yeah,
don't know what your size was, but what was the compliance rate like?
so we only had 27 in the pilot study to begin with, and we lost 3 in the first 3 weeks before the actual randomization. And then after randomization, we lost 1 from each group. So we did lose a few, I guess, but we still had enough to be able to, make statistical, analysis of what happened. I mean, we would love to be able to do a bigger trial where we had a lot more people and really monitor compliance and all that sort of stuff better. So in terms of the actual compliance, it was a self-rated compliance. And for both groups, that was really quite good. I can't remember the numbers right off the top of my head, but they were in the 80% for both groups of sticking to the diet that they were supposed to be on. So adherence was quite good. We'd love to do a bigger study where we could actually, have the numbers to be able to make more comments about those sort of things, as well as, if there's a particular type of pain group that did better with the diet and that sort of thing. The problem with that sort of research is that, getting funding is next to impossible because nobody makes any money out of doing that. So, I don't know if those studies will ever get done properly because then there's just no funding out there to do them. So it's a little bit of a misnomer when people say, oh, there's no research looking at that sort of stuff. Well, no, there isn't, because it hasn't been done. It's not to say that those things aren't true, and it's going to be difficult probably to get the evidence base behind us when the studies aren't being done. And as you would know yourself, trying to run your own trial, having to crowdsource fund it, it's very difficult to get that research done.
Yeah, I think, I mean, yes, I mean, I looked into it, so they are wildly expensive, particularly to do very powerful studies. And so it's one of those things where, you see that if you're not a pharmaceutical company with billions of dollars at your disposal, it becomes very difficult to do high quality research. Yeah, fortunately, we've got some funding now that we'll be able to do some of that, which is what I'm excited about going forward. What are you actively doing research in some other topic right now, or do you have another study that's ongoing or about to start?
So no, so that was all those studies that I'd sort of done up to this point was for my PhD, which I've now finished. So I'm back just working clinically at the moment, but I'm still having some discussions with the uni about potentially running another dietary trial specifically for low back pain. So we're looking at that, but I'm not sure whether that will get off the ground or not. But no, I'm not doing any research at the moment.
In your clinical practice, are you? I assume you're using nutrition to treat some of these issues. What other things? I mean, because obviously nutrition is extremely important, but there are certainly other things that actually can be beneficial. So, what other things do you use in addition to diet for chronic pain?
Mhm. So as I said, most of what we do is education. So once we sort of get people to the point of being more active and getting back into, doing a gym program or something like that, then we refer them back to exercise physiologists and other people that we work with. But we do focus a lot on lifestyle stuff. So that includes looking at sleep and trying to improve, their sleep health and, all the stuff that I guess gets talked about a lot in our space in terms of, blocking blue light and getting out and getting sunshine in the morning and all those sorts of things that don't tend to necessarily get talked about for chronic pain patients either. So we do a lot around that. Obviously, the psychologist sees them a lot for looking around like the mental health side of things. But the other thing that I guess I do from a physical perspective is we do a lot with graded motor imagery for trying to help people. So if you think about the way our brains work when we're trying to understand our world around us, if we're watching somebody do an action, our brain sort of borrows some of the circuitry that's involved in us physically doing that and gives a little bit of a trial run so we understand what that other person is doing. And so if we've got somebody who has chronic pain and physically can't do a task, and usually the way that I would do this with somebody is we pick a task that they just can't do anymore that was a favorite hobby they had, like golf or something like that. And it's okay, this person would love to get back and do golf again, but they just can't imagine their back pain so bad they just can't even, contemplate doing something like that. So what we do is we use graded motor imagery and say, okay, well, at the moment, because your nervous system is so sensitive and your brain is so aware of that activity, and it's already, setting off all the warning bells before you even think about doing it, we sort of have to desensitize the brain's processing around that task. So we would get them doing something like watching, YouTube clips of people doing some golfing stuff, because what's happening in that situation is that they're using some of that circuitry that would be involved in actually doing that task task, but in a smaller way. So you're giving it a little bit of a trial run, and you're almost desensitizing the process toward getting back to doing the thing that we want to get them doing in the long run. And so we sort of take that end goal of playing golf and we pull it back into component parts and start to desensitize the processing that occurs to actually have to do that task. So we get them watching YouTube clips. We then get them mindfully imagining doing the task themselves. So sitting somewhere nice out in the sun in the morning, having their coffee and shutting their eyes and imagining them being pain-free and being able to hit the golf ball, and practicing that through their repetitively, so that the brain's getting used to using that circuitry again, and then move it back towards getting them maybe standing in the backyard and holding onto their golf stick and just imagining that they're going to hit the ball, and maybe even just doing some very slow, gentle stretches into rotation. And so we're sort of taking the thing that they can't do and pulling it back into bits, and then just instilling safety all the way back towards that thing. Because what we tend to do at the moment with rehab is say, okay, yeah, well, you're weak and your range of movement's not very good, and you want to get back and play golf. So let's just get you out there doing it. You sort of throw them in the deep end. And the problem with that is that the brain immediately goes, no, this is threatening, this is dangerous, we need to protect, and pain, increasing your pain is the most appropriate way to stop you doing that task. So instead, what we have to do is take that thing and pull it apart backwards and basically relearn the way to do that task without setting the car alarm off necessarily. So we do a lot of practical work around that sort of aspect of helping people graduate back into the thing that they want to do, rather than just trying all the time and setting people up to fail, so that it just reinforces the problem that they got in the first place. And once we sort of get them to that point where they're understanding how to do that process and they're getting a little bit more active, the diet's going okay, they're maybe lost a little bit of weight, they're getting back walking, then we'll send them back and say, okay, let's get you back if you want to go back to the gym, or let's get you back doing some of those other hobbies and things that you want to be doing. So that's sort of the approach that we use with people.
Yeah, it's interesting because athletes will often do a similar process, visualization of what they're about to attempt, and so they kind of run through it in their mind over and over again. It does
Absolutely.
seem
And
to
if you think
improve
about it, it
outcomes.
makes total sense to do that. So if you think about the guy who's going to go and jump over the high jump at the Olympics, he doesn't just like wander out on the field and then just run and jump over it. He gets in his spot, and you can see him tracking it through in his head 2 or 3 times successfully before he actually goes and does it. And even though coaches and stuff might not realize what they're doing, what you're doing is you're priming the system. You're giving that circuitry a bit of a trial run before you actually get them to physically do the task. So they're more likely to be successful because the brain's not getting shocked by anything. It's already seen that. It knows how it's going to play out and how it's going to run. And so you're just adapting that same concept into pain management.
Let me one last topic before we get through our time is, the medications that people use now for pain management. Are there some that are better than others? I know there's this multimodal pain approach where they couple anti-inflammatories and nerve blocks and narcotics and various antidepressants or whatever. Do you find that is helpful at all, or do you find that just getting people off drugs altogether is works better?
Our general approach is to try and gradually get everybody off everything. So usually when like the people that we're seeing in our practice, they're on a whole heap of all different sorts of things when they come in to see us. And honestly, it's very rare that any of it's working very well. People are scared not to take it because they're scared that their pain is going to be worse. But when you start to think about that from the threat safety perspective, well, of course, your brain's going to be freaking out if you stop taking the medication that you're used to taking. And so your pain is likely to increase if you stop taking that. And so you will assume that medication was doing something to help. But when you look at all the side effects of everything that goes into all of those medications that people are on as well, then we sort of take the approach of trying to sort of sneak in underneath the radar and trying to just gradually decrease any of those things. We never want the medications to stop quickly because that's again, the brain goes, oh, what was going on? And your pain is likely to increase. So we try and sort of, get them to have a conversation with their doctor about, over the next month, let's just take, 80% of what we were taking before and just sort of gradually sneak it down. Because otherwise you tend to get in the situation where the GP that's been, prescribing the medication has a bit of a freak out at some point, says, oh no, we shouldn't be taking that anymore, let's stop. And then they just stop them suddenly. And brains and cranky nervous systems do not like that one little bit. So it's much easier to take a graduated approach. We don't really have much to do in terms of, prescribing medication and all that sort of stuff. It's sort of been done by, pain specialists and stuff that have seen people before they get to us. So we're really at that point trying to gradually get people off everything rather than, playing around with their medication. And so I can't say that I can say that there's any particular type of medication that I see is better than others. No.
Are you getting referrals from are people self-referring to you? Are actually some of the pain medicine doctors actually utilizing you as a resource?
Actually, we get most of our referrals from pain medicine guys. So I think, and it's probably a little bit because it looks good to have your multidisciplinary team that's looking after the pain patients. So often they'll be doing whatever they want to do with them off to the side, and they'll send them off to see us as well as part of a comprehensive pain management program. I'm not sure. I think that they always tend to do their stuff first, and I guess that's the way that they've been trained and what they're always thinking about. What intervention are they going to do, and that's they sort of do all that first and then send them off to us. But we would love to get more referrals from GPs and things like that, but it sort of feels like the GPs don't think that's their place. They sort of feel like, oh, okay, once they've finally got, chronic pain, then we'll send them into the pain management specialist, and then he'll do whatever's appropriate from that point. But really trying to, get GPs to refer earlier would be lovely, because then you've got the opportunity to actually make a difference before that, that nervous system gets really, really sensitized. You can start to try earlier in that process to change the way things are going. But unfortunately, it doesn't really happen like that.
Yeah, I mean, I'll just share again my experience. I know when I was operating on people and like I do knee replacement, I put them on a ketogenic diet, and the ones that would do that very often experience less pain, less swelling, better range of motion just from the get go. And so also it seems to avoid some of that, pain generating stimuli, which is again helpful. There are quite a few people from Australia that actually follow me. For I wanted to just share with you with people your contact information if somebody has an interest in pursuing pain management through your
Yes.
techniques.
Yep. We're happy to see anybody, obviously within Australia. So we do telehealth as well. We're located in Nowra, which is about 2 hours south of Sydney. But as I said, we can do telehealth. We've got a website which is step.com.au. So STEP just stands for Solutions, Tools, and Education for Persistent Pain. So people can get in contact with us through that website if they'd like to see us. Other than that, I'm not very active on social media. I do have a Twitter account, and I do see all your tweets that come out, but I'm a bit of a chicken when it comes to social media. I try not to do anything too controversial, and I just sort of monitor what everybody else is doing. So they won't find anything terribly exciting in my Twitter.
Yeah, it's a dangerous place, I have to say. You're probably best to stay out of it. Well, anyway, Dr. Field, it's been a pleasure. Thank you for being here, and thank you for what you're doing. I think you're doing a great service to many people, and all the healthcare providers are willing to kind of go out on a limb a little bit and do this stuff. It's great, and I think we're doing a great service to the world. So thank you so much. You have a great morning. I believe it's morning where you're at. So have
Yep,
a
it's
great
morning.
day, and thank you so much. The rest of you guys, we'll see you back tomorrow. Thanks, everybody. Okay, bye bye now.
Okay, thanks very much.